Hello everyone, myself Sriram K, Associate Professor in Department of Pharmacology. Today we are going to see the topic in the cardiovascular system, that is coronary circulation. So we already seen these two circulations earlier, that is systemic circulation and uh, pulmonary circulation. So this is coronary circulation is a specialized circulation. So right, we will get into the topic. So what is coronary circulation and why it is matters a lot? See, first, heart is a muscle. Okay, so heart is made up of pure muscles, so it needs constant oxygen and nutrition. So it works non-stop. Okay, from the birth it beats. Okay, it beats around 1 lakh times per day. So we cannot survive without blood. So every beat is matters a lot to us. Even brief interruption can cause damages. The unique challenge, that is, heart contracts yet must maintain its own blood flow. See, it heart itself, it's a contraction will happen. So for that contraction, it needs some energy, and also it have to maintain the blood flow also. So this is the main process in the heart. We already seen this. So this is the overview of coronary arteries. So first of all, the coronary circulation itself is a specialized circulation. So heart, we know it is a pumping system, so it will pump the blood over the body and also to lungs. For the pumping itself, it needs some energy. So that energy should be given by the blood. So the heart itself need to be supplied with the blood. So overall, the muscles of the heart needs some of the blood circulation. So the muscles of the heart are supplied with the blood vessels. So that circulation is called as the coronary circulation. Okay, so this is the overview of coronary circulation. So in that coronary circulation, what are all the arteries, veins are involved? So that we will going into the into the sessions. So first overview of coronary arteries. So the arteries that supplies the oxygenated blood. So there are two main coronary arteries arise from the aorta. So then first one is left main coronary artery, that is LMCA, and then one right coronary artery, that is RCA. So where it is origin is that both arises from the aortic sinus, so just above the aortic valve. So next we will get into the subcategory, that is left coronary artery system. So the left main coronary artery, it is short and divided into left anterior descending and left circumflex. So these are the two subcategories. The first, left anterior descending, is it is a window neck artery. So it is runs down front of the heart in intraventricular groove. So mainly where it supplies this artery, this supplies anterior wall of L, left ventricle, and anterior, that is two-thirds of the septum and apex of the heart. So this is the area this artery supplies the blood. Then left circumflex, this runs in left anteroventricular groove. Where it supplies to the lateral wall of left ventricular and some sometimes posterior wall. Okay, so all these arteries are we have already seen in the previous slide. So as we have seen in the slide, so we have made the complete picture of the arteries. Then right coronary artery, the right coronary artery system, it is runs in the right anterior ventricular groove. So it divided into many branches. So first one is right marginal artery, supplies right ventricular free wall. So it supplies to the right ventricular free wall. And posterior descending artery, that is PDA, in 85% of the people it is right dominant. Then SCA nodal artery, it supplies to the SCA node. As the name suggests, it is supplied to the SCA node. And then AV nodal artery, it supplies to the AV node. So all these are supplying to the right atrium, right ventricle, inferior wall of the left ventricle, posterior one-third of the septum, and SCA node 60%, then AV node 85%. So these are all the right coronary artery. So these are all the branches that supplies to the all the part of the heart. So next we will going into the coronary dominance. So determined by which artery gives off the PDA. So generally, most of the people it is right dominant. So as we can see in the table, the frequency is 85 percentage. So then left dominant only 8 percentage. It for some of them 7 percentage it will be co-dominant. So clinical relevance determines which area are at risk during the blockage. So mainly these are all we are saying this. If anything is blocking in these arteries, we can easily find out, okay, these are all the areas where the blockage may be happened. So for this it will be clinical relevance. Then once we have completed the oxygen supplying arteries, then we are going to see the coronary veins. As like the arteries, the coronary veins are also important, where it collects the deoxygenated blood. So most venous blood returns into via the coronary sinus. So this is the main coronary vessel that is in the coronary circulation. So major veins, we see that great cardiac vein accompany LAD and becomes coronary sinus. Then middle cardiac vein drains posterior part of the heart drains into this vein. Then small cardiac vein drains right margin. So right margin of the heart will be draining the venous blood into this vein. Then coronary sinus, so runs in the posterior anterior ventricular groove, then empties into the right atrium. So all these coronary sinus, so this is the major coronary sinus vein. This will empty the all deoxygenated blood into the right atrium. Then the Sbesian vein, that is small veins that drains directly into the heart chambers. So these are the small veins that directly drains the blood into the heart chambers itself. So next we can see the phase 6 blood flow. So this is a unique feature. Coronary flow is not continuous as like the normal systemic circulation. And during systole contraction, myocardium compresses intramuscular vessels and flow decreases, especially in the left ventricle. During diastole relaxation, compression relieved and flow increases to 70 to 80 percentage of the flow occurs here. Some of the clinical implications: tachycardia, shortens systole, diastole, and reduces coronary filling time, so can cause ischemia. And the regulations of coronary flow, you can see that primary regulator, vasodilators, vasoconstrictors. So all of these are uh, regulator of the coronary flow. Then collateral circulation and anatomous connections between the coronary arteries. So it can enlarge over time to provide alternative pathways. Collaterals can limit infractive size in the coronary obstruction. Some of the clinical examples: patient with a gradual LAD blockage may develop collaterals from RESC and survive with the minimal damage. So these are the some of the clinical correlation. As you can see, the coronary artery diseases, myocardial infarctions, unstable angina. So these are the complications we can see during the coronary circulations. So once we can get into the summary, so the arteries, veins, what are all the arteries we seen, what are the veins we seen, and the flow. So mostly during diastole and regulations also we seen. What are the collaterals, what are the clinical symptoms, and coronary circulation, that is heart lifelines. When it fails, the heart fails. So this is the complete coronary circulation overview. Uh, so we come to the end of the session. So thank you very much.